Thanks very much, Tom, and for everybody for inviting me to speak today. And I think I'm mostly going to stick to the national designation centres because you've heard a lot. You have heard, and you'll be hearing more about the research and new treatments as well. But and thanks also to the charity for their huge input into the service specification for the national designation centres. Alex mentioned this. It really was a huge triumph to have the patient voice in there. I don't think they would have heard us. Well, I know they wouldn't have heard us without it. So that was very, very important. Yeah, I have received honoraria from the main funders of cystinosis drugs, but as you know, in the NHS, you can't choose what you prescribe, so it doesn't matter. So some of these slides you will have seen last year in the similar talk. So as Alex also mentioned, these centres are for actually adults and children to deliver highly specialist management to patients. And the commissioners have proposed 3 adult and 3 paediatric centres in England. And the aim is to start next April. So we need to get our skates on. All the centres were invited to submit their answers to a long list of questions to NHS England at the end of September. So that's all in. I'm going to just run through the actual wording of this service specification just for your information, and testament to the patient's voice being part of this is the ambitious nature of the specification, and delivering it will be challenging. We will talk about that later. So paediatric services will provide assistance with the diagnosis of cystinosis, help with access to specialized treatment therapies. You can see it yourself: support and advice management of Fanconi, nutrition, growth development, chronic kidney disease, and then support for those people that need it, the initiation of renal replacement. Also important is provision of information. This is aligned to the charity's ambitions as well. Access to a full range of specialised children's services, research studies, important transition arrangements from paediatrics to adults, data entry, and the delivery of an MDT review every 6 to 12 months as needed. For adults, the adult services will focus on all aspects of cystinosis. Obviously, in a lot of cases, some of these aren't actually apparent in childhood now, particularly people that have been treated early with Cystagon. But of course, we will monitor the continuation of therapy and be involved in the management of all the multi-system complications that can be associated with cystinosis in some people. So to provide specific advice on treatment, again, accessing clinical research, and also managing Fanconi in those patients that have that, and supporting local services for renal failure. So, of course, if one is on dialysis, then one won't have dialysis in the centre, they'll have dialysis near where they live. Or if you have a transplant, then you'll have transplant follow-up near where you live or your own centre, and then be seen in a specialised centre for the MDT, the multidisciplinary team part of that. The diagram is from the specification document, and it's trying to really show, I think, that the principal role of the specialised centre is the coordination of services. So if somebody needs a lot of help at home, and their home is quite far away from the centre, then clearly delivering those extra care requirements will be done locally. But the extra value, I think, that will be added from the centre in that situation is to make sure that everybody's getting what they need, and trying to facilitate and bridge any gaps in care to make sure everybody's getting the best possible care that can be delivered. And so it's linked in with adults pediatrics with a good transition service, linking in with all the local services that are delivering and monitoring care, and also, of course, primary care and charities and research. So the centres will be required to deliver detailed transition plans from paediatrics to adults, will be required to provide a care coordinator, which may be a clinical nurse specialist, There will be named consultants. In fact, the requirement is for there to be 2 at least per centre. There is a requirement to involve patient support groups, to have well-developed information systems, to have the technology and facilities to deliver the care that's needed, and clearly a demonstration of how we will deliver interdependence with other services. So it can't be the case that the centre's ordering people to do stuff. There has to be a way to facilitate the delivery of what needs to be done, and that has to be demonstrated how you will do that if you're to be a national designation centre. We all know that people often have different needs and can be a number of complex needs. And for your information, this is what the document says we thought were essential and as necessary for the different specialties between pediatrics and adults. So, for example, nutritional support is absolutely essential in pediatrics, whereas in adults there will be some dietetics input for sure, but it won't be as important as in pediatric services. Whereas reproductive health, for example, will be less important in pediatrics, but more important in adults. So those are the services that will be required to be delivered. Centres will be required to offer comprehensive assessments and provide recommendations for care, including promoting equity of access for everyone, providing high quality holistic services through integrated personal care plans, facilitated a coordinated approach to investigation, treatments and with specialist healthcare and social care support, taking into account needs of patients, their families and others who provide essential support, delivering evidence-based management as much as there is through the best use of education resources, high quality clinical care, obviously, but through a multi-professional healthcare team, excellence in research, education and training, data collection, and of course, working in partnership with patient organizations. So these are part of the specification document. This isn't something I've come up with. This is in the document, and we will be providing online access to investigation results, clinical letters through Patient View or the equivalent. And there's lots of platforms that will be delivering this sort of thing. So that's the ambitious aim. What are the challenges? Well, I think we all know that linking up care with lots of different parts of the healthcare system can be very challenging, and getting people just to speak to each other sometimes can be irritatingly difficult. But we're committed to get this right, and this will, I think, will be one of the major improvements. Well, I've put down developing and evolving subspecialty interests, and what I mean by that is most large centres will have all the specialists that you can ever think of. Some of them will be interested in rare diseases, but very few of them will have a lot of knowledge about cystinosis, because for example, in adult cardiology, there may not be very much experience of cystinosis worldwide. So it will really be a learning process of interested specialists to get to grips with this rare disease, and to almost develop a new area of interest within that. So there will be a period of time, no matter who is awarded these centres, where the different specialists will be coming up to speed with cystinosis, because a lot of people won't be coming at this with a high degree of experience of this rare disease. And then in terms of the implementation, there will be some challenge, I think, in getting the right specialists with the right patients. So I've heard from colleagues in France and in Germany where they've developed these centres, and after a while the patients are complaining, saying, we're seeing all these people, we don't need to see all these people, we're getting too much care. And that might seem kind of ironic with people that have been struggling to get what they need, but I think what we will try and do, I think, is try and cohort the patients that need to see, let's say, a neurologist and a speech and language therapist and a psychologist and a cardiologist, and try and work some sort of matrix so that you can get the right specialists all there, so that those patients can see all of those specialists, but not the people that they don't need to see. Whereas at the next clinic, other people will have a different sort of batch of specialists to see them. And that will probably be the most efficient way to try to deliver that. That was the Margate engagement exercise that I said. We all filled those in September, and there were 17 domains describing how a trust would satisfy the service spec. Now, for example, C7 providers will need to develop detailed care pathways across both elements of paediatric and adult nephrology care for the diagnosis and monitoring of relevant care processes, etc. This was the sort of, and that's just one of 17 questions that were required to be answered in detail. And they all said, please answer your question in full. Where there are a number of elements, please ensure you cover each as a part. So it was a very, very detailed application. And I think they were caught a bit by surprise, if I'm honest, because I think quite a few more people applied for the designation centres than they were expecting. And so there's going to be a second round of judgment on who will be awarded the service specification. So we made an inquiry last week with NHSE, and they said there was going to be a provider selection process document that we published before Christmas. I don't exactly know what that means, but on a personal level, this is very difficult, isn't it? So for professionals and for patients, there will be, in a way, winners and losers. So some centres will be awarded the extra money to pay more specialists to come and see patients with cystinosis, and others won't. And that's going to be difficult. But I think the key to it is to believe that this is more. This is basically more money than we ever had before. So this is better than it was. And let's just say your centre isn't awarded the designation centre money, and you'll be invited to travel to another centre for the multidisciplinary care. You're still going to get what you had before at that centre, almost certainly. You're just going to be getting something more from the designation centre as well. And professionally, I would be very sad if we weren't awarded it, but we might not be. We'll be in competition with other London hospitals to get that, and I just have to accept that if we don't get that award, we'll deliver our service in a slightly different way in partnership with the successful hospital. And I think we just have to get over that as a process for improved care. So I'm going to just slightly move on from designation centres. This is related, and Alex mentioned this in her talk as well. So rare renal and radar and renal association. Actually, the renal association is now called the UK Kidney Association. Sorry about that. I've got the old logo on. And so rare renal is a resource for lots of rare diseases, including cystinosis. And you can click through those to try and find information about various rare diseases, including cystinosis. And all the rare diseases are trying to make this a bit more user-friendly, a bit more informative. And I have to admit, I think maybe I have a little bit of work to do to try and improve that website, and maybe I'll catch up with you, Tom, and the other trustees afterwards to see how we might do that. There is patient information on rare renal, and various support groups are referenced in that. Radar, Alex also mentioned this. So this is the registry of rare diseases, some not so rare, but cystinosis genuinely is one of the rarer ones. And recruiting to Radar will be part of the national designation requirements. So if you're a doctor working in a designation centre, you will be asked to register your patients on Radar. Clearly, they have to consent to do that, but you'll be asked to do it. So Radar is a rare disease registry, as you know, and it holds various domains and patient information. It uploads some information automatically from patient files once you've obviously consented to sign up, but quite a lot of data are not currently stored on Radar about patients' clinical progress in particular. So blood test is easy to upload that. whereas things like quantifiable measures of crystals and muscle strength, swallowing ability, and all those sorts of things are not captured on radar at all at the moment, and that's the next challenge. This is just a screenshot of a cystinosis page, and this is the recruitment as of November 2021. I think that's 127 patients, something like that, registered on radar, and that's adults and children. That's definitely not the whole cohort in the country by some way, and so we've got a bit of work to do to try and get more people registered onto radar. So what's next with radar? I think I showed some of these slides last year, and this actually links quite nicely to what Professor Levchenko was saying about trying to work out if we can somehow dissect which patients get which problems, and that's very difficult in a rare disease, as we've already touched on. But one way to try and do better is to have more refined, detailed genetic information on more people, and then being able to run that through clever algorithms to work out some sort of prediction scores. And so the idea around the NIHR bioresource is that we can take blood off any patient with that consents with cystinosis, that is stored, and then in the future different genetic analyses can be performed, or any other sort of analyses can be performed on that stored sample. And there are centres all over the UK that are able to recruit to different bioresources. And just a sort of genetic slide, really, to remind us that that within the gene there are quite a number of mutations, and whether it's within the cystinosis mutation or whether it's other related genes that will make the difference, is how the whole genome method will improve things. And then just a couple of slides on, well, one slide actually, on a paper that was published this year, quite recently, on an international cohort study. I've only put the first 5 authors, but there are lots of authors on there, including Professor Levchenko, and using databases across Europe to try and show different patterns and different trajectories depending on different characteristics. And what this shows, at least for this cohort, and this is a very historical cohort, so some of these patients were recruited or were recruited to the database a very long time ago. But what this suggests is, if you look at the graph on the left, this is the age at which somebody started taking cysteamine, and then how long what the kidney survival is. And this shows that if you start cysteamine under the age of 1, then at the age of 24, 40% of people have still not had a transplant or on dialysis. Whereas if you start after the age of 2, by the age of 24, only about 10% of people haven't had a transplant or have started dialysis. And which really shows that if for treating cystinosis, the earlier you can start, the better, by a mile. And that's the biggest single thing that you can do, is start treatment early. The second box does show that it is important to try, at least, to achieve decent levels of white cell cysteine if you can. And these seem to improve your chances of not needing, or at least delay the day to needing dialysis or a transplant. And that does appear to be important, particularly at a younger age, naturally. But by a relative gain, starting early is better. But of course, there's nothing you do about that in hindsight. Once you've started your treatment, all you can do after that is take your treatment and try and get good levels if you can. Quite a lot of people can't achieve levels of 1 or less on maximum treatment, but that's where we are. And whether we should exceed what we currently believe to be the maximum dose, or whether we think that achieving the best you can is enough, or maybe you don't need to achieve that absolute precise level, we still don't really know that. I think it's probably fair to say that to get your dose, your white cell cysteine level to near target as possible with as few side effects as possible clearly has to be the aim. And then the third box is talking about some analysis of a few mutations in the cystinosis spectrum. And at least on this analysis, which is quite a sort of a macro analysis, if you like, there was no association between the different mutations they looked at and the age at needing to have a transplant or starting dialysis. So, but I think there is a lot more potential in the genetics world to further refine that. That's a paper published just very, very recently. And so, yes, I was asked to talk about future avenues and therapies, but you've already heard from Professor Levchenko. You're going to hear from Herbie, and you're going to hear about the contact lenses. I'm not going to say anything more on those. I haven't seen anything new out of San Diego on the stem cell transplant patient. I'm not sure if they've done more than one still. I don't know if anybody else on the call knows the answer to that. There's the Cystinosis and Me app that I don't know if any of you have had a play with. I think that might be useful for some people. It's available on different app stores. And what I've certainly been encouraged by, and actually probably facilitated over COVID, has been the better networks amongst professionals and also patients. And I think this call is also a testament to how the better networks have improved communication between patients and between patients and professionals and each other. So I'll stop there and thank you very much for listening.